First state for today is of a 24-year-old female. This is Katie, a resident of Maharajganj, UP, who is a gravida 2 para 1 with 1 abortion, and she presented to us with paroxysms of headache with sweating and raised blood pressure records since last 1 year. Start with her previous pregnancy. She had a spontaneous conception in December 2020. And in Feb 2021, she was noticed to have hypertension in her ANC visit with a maximum BP of 230 by 120. And she was started on calcium channel blockers and beta blocker. In August 2021, and with a gestation of 28 weeks, she had stopped nifedipine for 10 days. And that BP shot up to 180 by 120, and she was restarted on the same. And in the following ANC visit, the patient had an intrauterine death with a female stillborn. After that, and she was on calcium channel blockers, beta blockers, and alpha blocker, and alprazolam for the palpitation used as an anxiolytic. And she was poorly compliant to the medication, and there were no BP recordings during this period. And on 11th of October 2021, she has a spontaneous conception, and she was referred to SGPGI in view of preeclampsia in the previous pregnancy. And when she presented, she was on amlodipine, labetalol, clonidine, and ecosprin. She had no history of preceding episode of flaccid paralysis, salt craving, or proximal muscle weakness. No history to suggest any Cushing syndrome. No history to suggest hyperthyroidism. And for systemic causes of hypertension, no history to suggest any renal failure or a cardiac cause or a vasculitic cause. In the past history, she was diagnosed with hypothyroidism in this pregnancy with a TSH of 7.42, and she was started on thyroxine of 50 microgram. And she was overt diabetes and started on split mix insulin. In the family history, there was no significant history of neck mass or abdominal tumor or young CVA or sudden death. However, she gives a history of young onset hypertension in the brother, though further details are not available, and he is not on any medications. In the general physical examination, her BMI is 20 with and a blood pressure of 156/90 with no difference, with no significant difference between the upper and the lower limb. She didn't have tachycardia. She had pallor. She had no neurocutaneous markers, marfanoid habitus, or mucosal neuromas, or any neck mass, or no pedal edema, no neck or abdominal bruit. In the systemic examination, she had stria gravidarum. The rest of the systemic examination was normal. So she's a gravida 2, para 1 with 1 abortion, presented at 25 plus 3 weeks, and with young onset hypertension, primary hypothyroidism, and overt diabetes. So she was with the obstetric care, and the initial investigations revealed a microcytic hypochromic picture, anemia, and low ferritin levels with an elevated TIBC. She was transfused iron for the same. And her chemistry, sodium and potassium was normal. The spot urine PCR, the initial value was 1.77, which was high. And as then when the BP got controlled, her spot protein creat ratio was normalized. She was biweekly monitored for the preeclampsia, and the rest of the investigation were normal. And the funder showed a grade 3 hypertensive retinopathy, and 2D echo showed grade 1 LV diastolic dysfunction. Her USG renal Doppler showed no renal artery stenosis. Other workup, ANA was negative and anti-beta 2 GP was negative. So she was with the obstetric care, and she was being worked up for preeclampsia. In view of high suspicion,
You want to ask them whether they have any questions so far?
Any queries till now?
Probably you can proceed. Only thing whether anyone worked up for any other cause of hypertension before coming to SGPGI?
No, ma'am. She was referred in a view of preeclampsia only. She was not worked up.
Because people have put her on alpha blocker and also whether someone suspected anything or just
no, ma'am. She had no previous investigations, ma'am.
Okay. Please proceed.
So in view of high suspicion, because she had a grade 3 hypertensive changes and a chronic hypertension, ultrasound KUB was done, which was apparently normal. And in view of high suspicion, again, we went, the obstetric team went ahead with MRI abdomen. And these are the MRI pictures showing a right adrenal. This is a T2 axial image showing a right adrenal mass of 3.4 into 2.2 centimeters, which is hyper intense, and a left of size 6.7 into 5.7 centimeters, which is appreciated well in these sections. And further, urine metanephrines and normetanephrine was done, which showed a significant elevated metanephrines. Normetanephrine, sorry. So in the hospital course, she came to us in April and she was on clonidine, amlodipine and labetalol that time. We tapered and put her on an alpha blockade. In that period, we evaluated her to have a pheochromocytoma, bilateral pheochromocytoma. And the maximum dosage of alpha blockade was 25 mg per day. And beta blockade went up till 1.2 gram per day, and by termination she was on 1 gram per day, and nifedipine to a maximum dose of 100 mg per day. And we had an interdisciplinary meet. The endosurgery team had decided for an interval adrenalectomy, and in case of any hypertensive crisis during LSCS procedure, so plan was to operate during that time. And the obstetric team followed her up with a weekly fetal ultrasound and a preeclampsia screen bi-weekly. And the plan for delivery was at fetal maturation at around 32 to 34 weeks, and no, without a dexamethasone cover, since it would precipitate the hypertensive crisis. The anesthesia team were alerted, and they were ready with nitroglycerin and nitroprusside, esmolol and phentolamine. And the neonatology team anticipated the complications of neonatal fetal distress, IVH, and hypotension. So she was delivered at 34+2, and the crisis during intra-op was managed with IV nitroprusside. And it was a male baby, 2 kg with Apgar of 5 and 7. And the child had respiratory distress, which required a CPAP for 36 hours. And she was discharged on prazosin of 25 mg and nifedipine of 70. Op, and the features are confirmatory for the bilateral pheo. T2, I mean, the CCT shows contrast enhancement with interspersed hypodense areas. She underwent a laparoscopic and she required nitroprusside, nitroglycerin drop. On post-op day 7, her urine normetanephrine was near normal. This is the view of the cut section, which shows a yellowish brown tumor with areas of hemorrhage of the left and the right adrenal. And this is the high power view showing polyhedral cells with pleomorphism and a slight atypical mitosis here and there. And this is a low power view showing the tumor cells in nests and interspersed vessels and hemorrhage. So it was pheochromocytoma, and a lymph node was dissected, which was reactive lymph node hyperplasia. In the follow-up, we did a gene sequencing for MEN2A and VHL gene, which was negative, and further followed by a whole exome panel, which was negative for mutation. And now we have planned a large deletion through detect large deletion in the VHL gene. Currently, she is on steroid and mineralocorticoid replacement, and she is off antihypertensives. Any queries? Or comments?
Yeah, good case. Only thing, there was a cortical sparing adrenalectomy attempt because your voice was breaking in between, so I didn't hear it properly. Was a cortical sparing adrenalectomy attempted, or it was straight bilateral adrenalectomy? What is the protocol in your center for bilateral masses for young patients? Do they attempt, or it is just total adrenalectomy?
Ma'am, we had attempted a right cortical sparing adrenalectomy since the lesion there was small and the left was a complete adrenalectomy.
So what was the cortisol, status post-op?
Her post-op cortisol was 27 nanomoles, and so we started her on Visolone. And in the follow-up, the next month, the PRA was 2.8. So then we started her on Fludrocort.
Okay. And MLPA detected last deletion of VHL was
No,
what
ma'am,
was told?
we are planning for
Okay.
to do an MLPA.
Okay. Your voice is breaking in between. That's why. Sorry.
You can ask whether she can hear you clearly now.
Ma'am, is it clear now? The voice is clear?
Overall, it is clear only, but in between it is breaking. You can proceed.
Okay. So pheochromocytoma is a very rare tumor in pregnancy with incidence of 0.007% in a large series of 30,000 and odd pregnancies over the last 20 years. However, autopsies show a higher incidence of 0.05 to 0.1%. The maternal and fetal mortality is approximately 40 to 50% if untreated. And after treatment, it is reduced to 5% for maternal mortality and 15% for fetal mortality. So the maternal catecholamines will not hardly cross the placental barrier, and the umbilical cord contains only 10%. And placenta is the only non-neuronal tissue to express the norepinephrine transporter. The uteroplacental COMT pathway and the monoamine oxidase pathways metabolize the catecholamines, and therefore the fetus is not affected. The high basal catecholamine secretion in the fetus, though there is high rate of secretion, but the circulating concentrations are low due to the high clearance. However, post-delivery, the umbilical cord contains a high, elevated normeta and metanephrines, which is expected due to the neonatal surge. And the maternal effects are in the form of hypertensive crisis, syncope, shock, acute coronary syndrome, cardiomyopathy, arrhythmias, and rarely aortic dissections. On the fetus, both the hypertension as well as the hypotension will cause the disturbance in the flow in the uteroplacental circulation, leading to placental abruption, intrauterine hypoxia, and intrauterine growth retardation. Therefore, a balance between the hypertension and hypotension has to be there. And how do we differentiate from preeclampsia is that PHEO usually presents in an early gestation period with typical paroxysmal symptoms. However, preeclampsia is detected after second or third trimester, and it is usually moderate and sustained hypertension. Edema and proteinuria and weight gain are present in preeclampsia, and lab features speak for itself: the elevated uric acid, creatinine, a low platelet count, microangiopathic hemolytic anemia, and elevated liver enzymes. When we have other features like we had in our patient, severe retinopathy, cardiomyopathy, hyperglycemia, which was in our case also, which was reversed after starting of alpha blockade, and syndrome specific findings such as cephalate spots, freckles, and fibromas go in favor of pheochromocytoma. So in the diagnosis, the biochemical diagnosis must be confirmed. And in preeclampsia, there is a slight amount of raised plasma catecholamines, and the case reports have shown up to 1.66 times of elevation. And so diagnostic tests are similar to non-pregnant patients. So more reliable tests are the plasma as well as the urine metanephrine and normetanephrines. And interfering drugs have to be stopped during evaluation. And imaging modalities, pregnancy, in pregnancy, ultrasound and MRI are the safest ones. So we have to opt for the same. And the diagnostic sensitivity of MRI is 90 to 100%, but spatial resolution is inferior to CT. And the specificity is around 70 to 80%. Gadolinium is not contraindicated in pregnancy. However, the MIBG is not safe for the fetus because of the placental transfer of isotope, and that will lead to the iodine and radiation exposure. So the main aim in the medical management is control of the blood pressure, the heart rate, and volume depletion, which should be restored, and protection from the toxic cardiovascular effects. And the alpha blockade should be at least 10 to 14 days before surgery. And this is the target for non-pregnant patients, in sitting BP of 130 by 80 and standing BP of more than 90 to be maintained. However, the target in pregnant is controversial. Though the European guidelines and even the Indian guidelines for the chronic hypertension in pregnancy without signs of end organ damage is less than 150 by 100. And in presence of end organ damage, it is 140 by 90. A recent paper in the current cardiology reports suggests in pheochromocytoma low normal systolic BP of 90 by 110, and to intensify the therapy at 36 weeks and the goal of systolic BP is 90 to 100. And with beta blockade to target a heart rate of 80 to 90, which has to be started at least after 1 week of alpha adrenergic blockade. And calcium channel blockade, when both when the BP is not controlled with both the medications, then it has to be added over the next 2 to 3 weeks. Just about the medications, phenoxybenzamine, the only side effect of this is that it causes irreversible blockade and it crosses the placenta. And so we should be aware of the neonatal hypotension and respiratory depression. In dazoxin, this is prevented. Dazoxin and prazoxin, this is there is no crossover to the placenta, as well as the blockade is reversible. And phentolamine for emergency, for hypertensive emergency. And then beta blockade, metoprolol is to be safe compared to propranolol or atenolol. And labetalol has both alpha and beta blockade, but the ratio of alpha to beta blockade is varies from patient to patient. So initially, upfront, we should not start with labetalol because the alpha blockade is less. And esmolol for hypertensive emergencies, and short-acting nifedipine and nicardipine as calcium channel blockers, and amlodipine as a long-acting drug. And regarding surgery, a laparoscopic adrenalectomy is the preferred approach, and timing when detected within the first 2 trimesters. Preference is to do recommended to remove the adrenals in the second trimester, that is between the 12 to 24 weeks as organogenesis is complete. And in the third trimester, when medical treatment is sufficient, it is recommended to postpone a resection until either delivery or after it, due to the poor accessibility of the tumor. So the outcome mainly depends on the when the diagnosis was made, and metanephrine levels of more than 10 times the upper normal limit, and if alpha blockade was not initiated. However, the positive pathogenic variants and PPGL syndromes were less likely to develop adverse outcomes. And regarding the timing and route of delivery, there is no consensus regarding the preferred route. Though in a few case series, it has been shown that the high mortality rate was there in the vaginal delivery, around 31%, and cesarean section 19%. These are all from 1988 to 2010. So with advancement of the epidural analgesia and cutting down the second stage of labor through instrumental vaginal delivery, so even vaginal delivery is possible. So this is a recent publication in the BJOG, which suggests that twice as many women carried their pregnancy to term when tumors were removed antepartum as compared to the women who with postnatal removal. However, there was no difference in maternal mortality or any benefit in the offspring survival. Only noted this thing, they noted the fetal distress at birth was nearly tenfold higher in the ones where tumor was removed after surgery, after the delivery. And there was no difference in maternal or fetal mortality between the vaginal delivery and the elective LSCS. So this is the summary slide for my presentation. So when a symptomatic pregnant patient is there and you have a high suspicion of pheochromocytoma, you have to do a 24-hour collection followed by an MRI. And if it is positive, to start with an alpha blockade and beta blockade to control the tachycardia. And if less than 24 weeks, go for a resection. And if it is more than 24 weeks, plan for an elective section or a vaginal delivery, depending on the expertise in the institute, and resection of the pheochromocytoma at the time of delivery or at interval of 4 to 6 weeks. And following which, we have to do the catecholamine levels and monitor the PRA if bilateral adrenalectomy is done, and cortisol levels.
Any comments?
Any comments, ma'am?
Very nice summary. I think this is always challenging when we get a PO in pregnancy. We have had maybe two or three cases only, again syndromic, because young patients. One is Vasna Madam's MEN family who was diagnosed with PO in pregnancy, and we also did the same. We carried her through pregnancy, and then the surgery was done after an interval of 6 weeks. We haven't done any in the second trimester as of now. Thank you for that update. Vasna Madam, do you want to tell anything, Madam?
Vasanta, Dr. Vasanta Nayak.
Can you hear me?
Yes, Madam.
Good morning. A very good presentation. I don't have anything to add. We have not had so many patients. We have only 2 patients.
Yes, Madam. 3 patients, Madam.
They all did well. No?
Yeah, they all did well, Madam.
Very good. Thank you.
I think we can give the follow-up of the genetics in the next presentation. This should be definitely syndromic. We'll be keen to know the follow-up.
Yes, ma'am.
Thank you.
Thank you.
Good morning to all. Now we move on to the second case. So this was a 18-year-old girl from Gorakhpur who was first diagnosed as insulin-dependent diabetes mellitus at 11 years of age in 2015. And she was started on insulin therapy. However, her compliance was poor and she lost to follow-up, only to present after 4 years and landed up in DKA. Which was managed accordingly, but her compliance remained poor. And this time she presented to us at 18 years of age in August 2022 with complaints of painful movement of left eye for 20 days, left eyelid droop for 15 days, double vision for 15 days, and headache for 10 days. If we see her HbA1c, at the time of diagnosis, the HbA1c was 15%, and it remained on the higher side. And even on this presentation, the HbA1c was 13.2%, indicating the poor glycemic control in this girl. This eye pain was gaze evoked, initially was dull, boring, and later of throbbing type. There was associated minimal lid edema and redness. The eye drop was progressive and it even led to diplopia. There was restriction of eye movements in all the directions of gaze. There was photophobia which was present. However, there was no associated eye bulge or any eye discharge. There was no diminution of vision. The headache that she complained was frontal and non-throbbing in nature and was not associated with any vomitings. There was no history of any abnormal behavior, seizures, facial asymmetry, limb weakness, or any other focal neurological deficits. She did not give any history of fever or any localizing history suggestive of any infection. She did not have a history of facial trauma. There were no hyperthyroid features, no history suggestive of sinusitis or any dental caries. However, there was history of multiple pustular acne over her face for past 2 months, probably an infected nodulocystic type of acne. Her other histories did not reveal any significant history of sinusitis or recurrent infections in past. The family history did not reveal of any cardiovascular events in the family or suggestive of any other autoimmune diseases. She achieved her menarche at 13 years of age and had regular cycles. So at the time of presentation, her anthropometric parameters reveal the BMI was 21.2 kg per meter square, which was normal. Her BP was 122/68 millimeters of mercury. She did not have any significant anemia indicated by pallor. There were healed hyperpigmented marks over her cheeks, small pustules over face and neck. There was ring-shaped lesion with central clearing over her left thigh and groin, indicating a tinea infection. The nasal cavity did not reveal any blackish discharge, nor did the oral cavity show any palatal ulcer. There were no evidence of any tooth caries. The detailed eye examination was done, and it revealed that the eyelid, the left eye had ptosis, but the skin was normal. The conjunctiva showed mild chemosis. The pupils in the left eye was mid-dilated and was not reacting. The external ocular movement was restricted in all directions of gaze. Her fundus was normal, vision was normal. IOP in both the eyes were normal, and her sensations were decreased over the ophthalmic division of the trigeminal nerve. The detailed CNS examination further revealed higher mental functions as normal, and cranial nerve, as described before, there was third, fourth, and sixth cranial nerve palsy. She had sensory deficit of the ophthalmic division, and other cranial nerves was normal. The motor system and the sensory system was normal. There were no meningeal signs. And this was the girl when she presented to us with slight edema of the left eye, and there was complete ptosis. Her other systemic examination was unremarkable, and at the time of presentation, the capillary glucose was 336 milligram per deciliter, and the blood ketones were 0.3 millimoles per liter, indicating that she was not currently in diabetic ketoacidosis. So based on the clinical examination and history, the working diagnosis of a type 1 diabetes mellitus with poor glycemic control, currently not in decay, with left eye ophthalmoplegia, which was painful, with tinea infection was made, and with the probable etiology of cavernous sinus thrombosis, probably secondary to the infection of the face. And the other differentials that were kept was superior orbital fissure syndrome, secondary to infectious. This entity is usually described in terms of trauma, but it can also be secondary to infectious or the inflammatory conditions. Tolosa-Hunt syndrome, which is an idiopathic condition, inflammatory condition of the cavernous sinus and leads to the similar presentation. And diabetic ophthalmoplegia, which can cause cranial nerve palsy, but is very rare in type 1 diabetes.
Do you have any questions?
Many questions or comments?
Yeah, please proceed, please. I just wanted to know whether there was any nasal discharge or anything of that sort. So
No, sir, there were no nasal discharge. So her baseline investigations did not reveal any significant anemia. She had leukocytosis with polymorphic count. Platelets were normal. Her initial RFT and LFTs were normal. There was vitamin B12 deficiency, which was corrected later on. The D-dimer was raised, which was 0.64 microgram per ml. The ESR was 38 millimeters, which was raised, and CRP was positive. The initial coagulation profile was normal, and her thyroid functions were normal. We went ahead with the MRI, but before I discuss the MRI here, I would just like in brief to tell about the anatomy that is seen in the MRI. As we all know that the cavernous sinus are the dural venous sinuses, which are located on either sides of the pituitary and the sphenoid sinus, which is represented here on the coronal section. If we see the contents, in the center of the cavernous sinus, we have internal carotid artery, which is represented here, and the sixth cranial nerve, which is abducens inside. On the lateral wall, we have third nerve, fourth cranial nerve, and the two divisions of the trigeminal nerve, which is the ophthalmic and the maxillary. So the same is being represented. It is also important to note here that a normal cavernous sinus, which has certain concavity on either of the sides. So now coming to see the MRI of this child, we can see here that if we compare the right and the left, the right side, the concavity is maintained, but if we see the left cavernous sinus, it was very bulky, and there was loss of concavity. In fact, it was convex. Also, this flow void is because of the internal carotid artery, which is seen but is narrow on the right side. The other deficits, filling defects, was probably because of the thrombosis. If we trace this to the other regions, and we can see here that even their contrast enhancement was even seen in the superior orbital fossa. So this was indicating that this thrombosis probably extended till superior orbital fissure. Now, the sections of the orbit, if we compare the right and the left orbit, these are the recti which is present. And if we compare the right and the left recti, we can see here that in the left eye, the affected eye, the recti were edematous, more so in the superior rectus, but the other muscles was as well edematous. On the axial section, if we see the cavernous sinus region, the internal carotid artery, which is seen on the right side, it is seen attenuated on the left side. So that was because of the inflammation of the thrombus, which was present in the cavernous sinus, causing attenuation of the internal carotid artery, the cavernous segment. And this is just a contrast enhanced image, and it is showing the enhancement which is progressive towards the superior orbital fissure, just telling us that there was dural enhancement. There was a dura which was also involved in this region. A venogram was also performed. It did not reveal any filling defects in any other cavernous sinuses. But if we focus on this section, this is the left eye, and if we see, this is the area of superior ophthalmic vein. And if we observe very closely, there is a cut in the this venogram. So that is probably representing the thrombosis which is present even in the superior ophthalmic vein. So the MRI report read the same, that the left cavernous sinus was bulky with lateral convexity. There was a filling defect within the sinus that was extending up to the superior orbital fissure, and there was a thrombosed superior ophthalmic vein. The left internal carotid artery was attenuated. The left extraocular muscles were edematous, and the right side, corresponding right side, was normal. So the final impression of left cavernous sinus thrombosis with contiguous dural enhancement was made. Now, just to note that since the inflammation in this area were more, also a very rarely a possibility of inflammatory pseudotumor can be kept. So it was also given as one of the differentials. So now to identify the cause for this cavernous sinus thrombosis, a ENT consult was sought and nasal endoscopy was performed to look for any sinusitis. There was no mass or crusting in the nasal cavity. The maxillary sinus were normal. For further investigation, the blood culture taken on 2 occasions came out to be sterile. The nasal swab culture was negative. A fungal blood culture was sent, which was also negative. The initial workup, which was done for procoagulation state, like ANA was negative, lupus anticoagulant was negative. The further thrombotic workup was planned for later stage since the child was currently in the thrombotic period. She was managed with antimicrobials, which were given as broad spectrum antibiotics in the form of ceftriaxone and vancomycin, which was continued for 4 weeks. Antifungal was also added, which was fluconazole for 2 weeks. Anticoagulation was given by low molecular weight heparin, and it was followed by warfarin, and the doses were titrated based on the INR, which was kept between 2 to 3. Her insulin, the basal bolus regime was continued, and for the topical treatment was given in the form of eye lubricants, and for local tinea infection, cotrimazole ointment was given. This is her follow-up after 6 months. The cranial palsy is resolved. She was currently on the warfarin tapering dose. Her sugar charts was average, and HbA1c now had decreased to 7.8%. The procoagulant workup, which was done after approximately 6 months, did not reveal any. The beta-2 glycoprotein was negative. The factor 5 latent mutation was negative. JAK2 mutation was negative. Homocysteine, sorry, I've written negative. It was normal. It was 11.8 microgram per liter, and the normal range is 5 to 15 microgram per liter. So the homocysteine levels were normal. The protein C functional assay and protein S are still awaited and has been sent. Any comments?
Hello, Praveen, Nisha, any comments? We can't hear you, Praveen.
Hear me now, ma'am?
Yes, now yes.
Yeah, yes, ma'am. So when you initially sent the slides, maybe we thought we are going to hear about some mucormycosis. So it's like, so yeah, it's a surprise. So it's Good one. Anyway, the outcome is very good, man. I think it's the most interesting thing about this case is the child looked very well now. So it's we're glad to see that. It's the most important thing.
So
Yes, it was
that,
recorded. Yes, Nisha.
yes. No, the antibiotics were given just empirically for 4 weeks.
Yes, ma'am, it was given empirically. We could not find any source of the infection. So we just kept a possibility that probably because of the facial pustules that were present, so that could have been the cause. And
Okay. Thank you.
Might have been, I mean, in retrospect, maybe we can think that it was a bit long, but actually the current, at that time, it was quite worrisome, like her picture was really worrisome. So I think they erred on the side of caution to give it for longer period. Hello, Nisha, we can't hear you.
Yes, ma'am. Yeah, so we see that the nodular cystic acne also has kind of disappeared. Are there, I was just thinking loud, are there some sort of association between nodular cystic acne and some rheumatological diseases? So I guess you ruled out all those stuff now. So some of these things.
sir, in the review, when I was searching the literature, I could find that facial acne were, in fact, the cause for cavernous sinus thrombosis, which was reported in few cases.
All
So
right.
that could have been the.
That itself, the infective source, it's enough to explain this. All right.
Yes, sir.
Okay. Yeah.
And Praveen, which would be your conditions you're thinking of, you're telling us?
And I can
Rheumato-
remember, ma'am, I was just thinking of some Berger-like things, which has some association with this thing. I am not able to remember nicely now. So just a vague memory is coming up. Yeah, anyway, it's okay.
Right.
Should I proceed?
Yes, please.
We'll be discussing very briefly about the anatomy of cavernous sinus, the causes of cavernous sinus thrombosis, the relationship between diabetes and thrombosis, and finally its management. So as we all know that the cavernous sinus are the dural venous sinuses, which are located on either side of the sphenoid bone. It extends from the superior orbital fissure and posteriorly to the petrous part of the temporal bone. So what is important to learn here is the drainage of the cavernous sinus. So there are two things that we need to keep in mind. The first is that most of the connections of cavernous sinus to and from the cavernous sinus are all valveless. So the infections may go in either of the direction. Usually the drainage pathway that is here is from the ophthalmic vein and the sphenoparietal sinus and the inferior ophthalmic vein to the pterygoid plexus and finally to the internal jugular vein. The infections from the upper part of the face, which is the forehead, the nasal vestibule, as well as the upper lip, they drain via the ophthalmic vein into cavernous sinus through supratrochlear and supraorbital or the angular veins. The infections from the palate or the peritonsillar area or the odontogenic infection, they traverse through the pterygoid plexus and retrograde via the emissary vein, they land up in the cavernous sinus. The infections from the middle ear, that is the mastoid as well as the middle ear infection, they traverse through the superior petrosal sinus and the inferior petrosal sinus to cavernous sinus. And the infections from the sinuses, which is the sphenoid sinus, traverse through the sphenoparietal sinus, and from the ethmoid sinus traverses through ethmoidal vein, which is not shown here in the picture. So the causes can be broadly categorized as septic or aseptic. Septic is the infectious cause, which we'll be discussing in further slides. The aseptic causes can be trauma or post-surgery, tooth extraction, malignancy, dehydration, hematological. Here I would like to emphasize that anemia in itself is a very important risk factor, especially the iron deficiency anemia, that is a procoagulant state. Also the thrombocytosis, and obviously the hereditary thrombophilias. So for this site, most of the cases of septic cavernous sinus thrombosis, they come from the middle third of the face, of which the sinusitis, that is the ethmoid and sphenoid sinusitis as the major source. The middle layer infections, they account for around 10% of cases, and the oral and dental infections, they account for less than 10% of all cases. As far as the infectious organisms is concerned, the bacterial cause accounts for around 2/3 of the cases, with Staphylococcus aureus being the most common organism, followed by Streptococcus. Fungal etiologies are mostly seen in uncontrolled diabetes with hematological in immunocompromised states like uncontrolled diabetes or hematological malignancies. They can even be viral causes like CMV, herpes simplex, measles, HIV, or hepatitis virus. The clinical presentation is can be categorized because of three pathophysiology. One is because of the sepsis, which can occur, and that will comprise of fever, headache, and headache is seen in around 50 to 90% of cases, which is usually unilateral to start with, and then retroorbital and frontotemporal distribution. Meningismus can be seen in 40% of cases, and other features of sepsis like tachycardia, hypotension, etc. can be seen. The venous obstruction in the cavernous sinus thrombosis actually leads to venous obstruction from the other areas. And like if the involvement of superior ophthalmic vein is there, the eye symptoms in the form of chemosis, eyelid erythema, periorbital edema, or proptosis may be seen. And this is the most common presentation in 80 to 100% of cases. There can be dilatation and tortuosity of the retinal veins, retinal hemorrhage, and if the pterygoid plexus is involved, it can even cause edema of the pharynx and tonsils. The cranial nerve involvement is there as we discussed the anatomy. So the earliest cranial nerve to involve is the sixth nerve, as we saw that it was inside the cavernous sinus cavity. So it is more prone for involvement, and it is followed by third and fourth. These are saved because they are located in the lateral wall, and the effect is because they are covered with dura, so the effect is less. The other features are because of the cranial nerve palsies. The vision change can be there because of the diplopia. The loss of vision can be because of the involvement of central retina, artery or vein, or ischemic optic neuropathy. The loss of corneal reflexes will lead to corneal abrasion and ulcerations, and there can be loss of sensation over the face in the ophthalmic and maxillary division. So now coming to the important part, which is diabetes, the connection between diabetes and thrombosis. So we all know that for any thrombosis to occur, this virtuous triad has to be there, which is the combination of hypercoagulability, vascular endothelial dysfunction, and stagnant blood flow. So in diabetes, both in type 1 and type 2, there are changes in blood coagulability. And there are also alteration in the clot structure as well as the clot formation, kinetics of clot formation and lysis. These all occurs because of the changes in numerous coagulatory proteins. So we can see here that in procoagulant proteins like von Willebrand factor 5, 8, 9, 10, and 11, they are all increased in type 1 diabetes. The anticoagulant proteins like protein C, protein S, and antithrombin, they are decreased. The profibrinolytic proteins like plasmin, the activity is decreased, and the antifibrinolytic like alpha-2 macroglobulin and antiplasmin are increased. There are also other mechanisms that has been explained, like altered level of plasma metal ions and like magnesium, iron, calcium, zinc, and copper. They are altered in individuals with type 1 and type 2 diabetes. And they also have an impact on coagulation. And not just the diabetes, but the glycemic variability also accounts for the mechanism. So if there is poor glycemic control, that will lead to increased glycation of plasminogen, which is the fibrinolysis. So there is decreased activity of this plasminogen. Methyl glycoxyl, which is a byproduct of hyperglycemia, that inhibits the antithrombin activity. There are proteins which are elevated like complement protein C3 and alpha-2 antiplasmin. They get incorporated with the fibrin clot and prevent their lysis. And obviously, there are increased level of tissue factor pathways like factor 7 that will lead to the thrombosis. The other mechanisms that have been explained is that of endothelial dysfunction and platelet hyperactivation, most of which is same, that ultimately because of hyperglycemia, there will be decreased nitric acid oxide production, increased endothelin 1 secretion that will cause increased vasoconstriction, decreased vasodilation, and platelet inhibition. There is also a concept of platelet hyperactivation, that because of hyperglycemia, there are generation of reactive oxygen species that will cause oxidative stress and finally lead to hyperactivity of the platelets, and that will cause more of thrombosis. There is also a concept of NADPH oxidase that leads to platelet hyperactivity. So not many, cerebral venous sinus thrombosis in itself is a rare condition, but whatever has been described in literature is described in presence of ketoacidosis, because ketoacidosis itself is a procoagulant state. But I could only come across a few case reports which was described in patients in absence of ketoacidosis. And this was for a 17-year-old boy who had sagittal sinus and left transverse sinus thrombosis, and he was managed with anticoagulation. The diagnosis of this condition is based on the imaging, which is CECT head or MRI. There are direct and indirect signs that we have seen in our case as well. There is direct signs is expansion of the cavernous sinus, filling defects within the cavernous sinus, and indirect signs are in the form of intracavernous segment occlusion of the internal carotid artery, dural enhancement of the borders of cavernous sinus, exophthalmos, fat pad edema, secondary thrombosis, especially in the areas of superior ophthalmic vein, petrosal, or the other sinuses. And cultures has to be taken to rule out the septic part of the cavernous sinus thrombosis. The management, there are no specific guidelines for management, but aggressive use of parenteral antibiotics have been implicated. It has to be broad spectrum antibiotics with plus minus antifungals, depending if there is an immunocompromised state, like poorly controlled diabetes. The duration has been written as 3 to 4 weeks, and it may be extended up to 8 weeks. However, the recent literature also says that it should be continued 2 weeks after the resolution of symptoms. So that is there. About anticoagulation, there is no consensus, but it has been seen that it decreases the morbidity and mortality. There is EFNS, that is European Federation of Neurological Societies recommendation, the guide that guides for the duration of the anticoagulation. They say that if there is a transient risk factor in the form of fever, anemia, or any dehydration, so the duration should be 3 months. 6 to 12 months in the cases of mild thrombophilia, that is heterozygous mutation or high plasma factor level 8. Long-term treatment in severe thrombophilia with high risk of recurrence, like homozygous factor 5 laden mutation and other mutations, and indefinite if the patient has had 2 or more episodes of idiopathic thrombosis, which has been documented. The monitoring is done by INR, that has to be kept between 2 to 3. And in general, anticoagulation should be avoided in patients with meningitis because there is an increased risk of intracranial hemorrhage. There are other modalities like steroids. The role is controversial. The only potential benefit that comes from it is decrease in orbital inflammation, cranial nerve and vasogenic edema. And steroid therapy should be employed in patients, especially where we have adrenal or pituitary insufficiency. This is one of the complications of cavernous sinus thrombosis, where as we read that the sella turcica is closer in association with the cavernous sinus thrombosis, that may lead to the infarction in the pit. So that is one of the indications for steroid. The surgical intervention are mostly directed towards the infection to cause the debridement of the infection and removal of the infectious source. So the indications could be in the form of debridement in case of rhinocerebral mucormycosis, or in acute bacterial sinusitis to decrease the load of infection, like in sphenoidectomy, ethmoidectomy, or maxillary antrostomy. One of the complications is subdural empyema, so that may require craniotomy, or there can be orbital abscess that may require decompression. So to summarize, this is a rare entity, but with high mortality rates and the potential for significant disability, and therefore it necessitates prompt diagnosis and treatment. So in those patients who have appropriate clinical symptoms, imaging should be sought immediately, and aggressive institution of parenteral antibiotics should be done even prior to imaging results. Long-standing hyperglycemia may have a role in increasing thrombotic risk, and this highlights a potential association between CVST and hyperglycemic. And our case highlights the need to consider CVST among patients with diabetes, even in absence of ketoacidosis or hyperosmolarity.